Fermipex, we are deeply committed to advances healthcare through knowledge sharing and innovative solutions. As we kick off the year, we are excited to bring you this discussion on the latest advancement in molecular diagnostics and their practical application in infectious diseases management. In a time where precision and speed are crucial in diagnostics, understanding this algorithm is more important than ever. We are truly honored to have with us today Dr. Andres Arias. Hi, a, a pediatric infectious diseases specialist with an impressive background. Dr. Arias holds key positions at Hospital Universitario Erasmo Mayos, Clínica Médico Duarte, and Clínica Santa Ana. He also served as the medical director of InfectoPet and InfectoNorte, and is a dedicated faculty member at both the University of Santander and the University of Pamplona. A few housekeeping notes before we begin. The webinar will last approximately 1 hour. We will follow this with dedicated Q&A session. Feel free also during the presentation to submit your questions at any time using the chat or the QA box. I will ensure that they are addressed to Dr. Arias after the presentation. We appreciate all of you joining us from different time zones. It is great to have such a diverse audience with us today. And as the shiny request, please let's show your flag and show your presence in our chat box. With no further ado, I will want to introduce Dr. Arias. Dr. Arias, the floor is yours.
Thank you, Emily. Good morning, everyone. Please, if you can confirm if you can see my screen.
Yes, we can, doctor.
Okay, thank you. So, thanks for the invitation. This time, I wanted to update the clinical cases and make some insight into algorithms so we can usually and easily apply this into clinical practice. These are my conflicts of interest. As you can see, everything you're going to see is from my daily practice, and I can guarantee you the transparency of the information. So there are going to be 4 topics: the requirements for in-hospital development of algorithms, rules in molecular diagnostic. We already seen them at the last webinar, and from head to toe syndromatic approach with updated clinical cases and an insightful message of every algorithm. So the minimal requirements for in-hospital development of algorithms must have this in your hospitals: the antimicrobial stewardship programs. As I told you the last time, this is a continual program that must be in head of an infectious diseases and the microbiologist. And you must have these 2 really important items: the clinical antimicrobial stewardship, that's what I do, and the laboratory antimicrobial stewardship, that was the microbiology does. He is always trying to teach us what's the correct sample, what's the correct time for the test, and which are the complementary microbiology tests that we can use so we can have the best result for our patients. It is critical for molecular testing that we can have inside or really next site processing for on-time result. Molecular testing is on-site a POCT test, a point of care test for the patient. So you have to make a decision based on the result, and the result must be the most quickly possible for your patients. So another important message is the correct implementation. It must be implemented as a critical value, like a troponin. You must have the result and you have to be informed as soon as possible of the results so you can change your clinical decision on your patient. And you have to measure what are you doing if the test is giving you really insightful tools for making decisions of it is not being really useful in your clinical practice. So remember syndromatic molecular rule first. This is something I told you last time. Molecular testing give us this really impressive power of moving from medical school to theory to practice so we can now know the theological diagnostic for our patients. So what we have to choose is the best molecular test with the most possible targets and with the best sensitivity and the best specificity and the more quick test that we can guarantee for our patients. So we have to do internal validation in our labs, and we have to socialize with the staff about what technology we are having and the number of targets and the pathogens we can possibly detect. And we also have to teach them what are the limitations of the test according to the number of targets and what is not included and that we have to suspect in case there is no detection in our panels. And also we have to teach about the resistant genes. You know that genes are expressed in resistance are enzymes, usually like beta lactamase. So we have to teach them how to correctly interpret the genes that are detected in the panels. This is a key message. We have to use the panels as they are validated in the FDA. We cannot make a new validation outside the correct indications because if the panel starts to not be useful and it's because we are using it in a non-correct way, we are going to lose the utility of this molecular testing. I have only this message for IDs. These are PCRs, these are molecular testing. So if an ID choose to go outside the indication, it must be a conversation with the microbiologist. But usually we have to do it always by the indications that are approved by the FDA. We must ensure that our laboratories are linked to a real-time monitoring software. I teach you last time and I show you how we can use this molecular testing so we can have epidemiological data. So it is really important to know what do we get when we start using molecular testing in our institutions. What are the benefits and how we link it to real, perhaps to syndromic trends in our institutions. We must be aware of possible diagnostic mistakes. These are closed platforms, so we are not expecting a lot of pre-analytical or analytical phase mistakes, but we can have it. For example, if we are using gastrointestinal panel and we are using it without any indication or any approval from ID in completed format stool, we are not going to have an impact in our patient. We are going to be confused. If we are going to start using sepsis or BCID panel in negative blood cultures, we are going to have also a negative impact in our patients, and we are not going to have a reliable results in the molecular testing. In the analytical phase, it is always less expected. This is a closed platform, and in the post-analytical phase, it will depend of the education of our microbiologist and the result that is going to be given to the clinical to take decisions. What is our intention today is to know that this molecular testing must be, or ideally must be, adhered to an institutional algorithm. So we can ensure we have this kind of direction in how to use them and how to interpret them. But we must ensure also that professional healthcare workers and nursery medical staff must be educated in how to interpret where when to use it and which patient is going to be really benefit from this testing. We have to support our decision with our antimicrobial stewardship team that could be led by an ID specialist or a microbiologist. And what I told you, it must be linked like a critical error value, like a troponin. As soon as you have the result, you must inform it and you have to measure what are you doing with the result. What time does the microbiologist uh, last and give you the inform? And what do you do as soon as you are being reported with the patient? Are you taking actions? Are you changing your decision plan? Are you changing your coverage from antibiotics? Are you stopping antibiotics? Are you starting another antibiotic or changing the diagnostic plan with the patient? So make decisions. It's important. Even a negative result in molecular testing gives you really, really important information. And this is an really important thing I want to make sure for you. Some doctors goes to you and says like, it's negative. Now what do we do? So you reinterpret your patient based on your result, and a negative result, as we will see, gives you important tools so you can make decision on changing to oral route or stopping antibiotics or really going into other direction with another differential diagnostics. This was my last conversatory, my last conference in 2024 with ID in my country in these important congresses of virology. And what I did was an online survey, and I asked them, what are you looking forward in your molecular testing? I, I think I showed you this the last time. 66% of ID were really interested in the number of targets. They said, as more I can detect or I can rule out, it could be helpful for my clinical practice. And then we have almost everyone. Timeless, specificity, and sensibility were the most important tools. So I want that you have these two red spots on your mind because it's what we're going to do today. So what do we have? We have these panels right now. You can see respiratory panel, meningitis and encephalitis panel, BCID or sepsis panel, pneumonia panel, bone and joint panel, and GI or gastrointestinal panel. What you can see here is the correct sample we are expecting in the laboratory from you to take. But if we do not have a correct education in the personnel, perhaps you are going to take the pneumonia panel in nasopharyngeal swab. And if you cross-react these samples, you're going to have um, a really bad result because, as I will show you, pneumonia includes a lot of pathogens in lower respiratory tract that are colonizing our nasopharyngeal tract. So if we change the sample that we are taking because we don't align with the indication, we're going to have false positives that are going to be including or giving us false data that will perhaps make we overuse antibiotics and we overdiagnosed. So these are the really important samples we wanted you to know that are the preferred samples and the validated samples you have to take for making this molecular testing. And important thing, it's validated in pediatric and adult population. So it's for all ages. And what's coming next in diagnostics, so you to know, and I know that as my country and like my country is going to be very useful, it will be the BioFire Filmarite Tropical Fever Panel that is going to include chikungunya, that we know we have it, but we are not diagnosing it, and we are not monitoring the this virus, but we know Brazil is having peaks of chikungunya. Right now, Peru is having peaks of chikungunya. So perhaps we are not so far from having chikungunya, also with the already known dengue fever. Also, leptospira that has this really difficult testing sensitivity in normal serologies. So it's going to be a life-changing panel. And of course, Plasmodium, so we can have malaria diagnosed. This is going to be in 50 minutes. And as you know, molecular testing can detect polymicrobial infections. So perhaps in the implementation of this panel, we will see chikungunya with dengue in the same result in the same patient. So going into our conference from head to toe, syndromatic approach, I hope this is going to be very meaningful to you. And we were going to start with respiratory panel. The first I wanted you to know is it has viruses and atypical bacteria. This is really important because guidelines, usually in adult population and perhaps some guidelines in pediatric populations, are trying to give us, like, if you are suspecting a respiratory infection, perhaps you must trying to go for RSV, for COVID, for influenza, but we forgot the other viruses that are almost 50% of the total of circulating viruses. So if we go negative in rapid respiratory testing that are immunochromatographic tools with less sensitivity, only 50%, we are going to miss the other causes of upper respiratory infection, and we are going to overuse macrolides in asthmatic crises, in adults or pediatric populations that has more symptomatic clinical scenarios, and perhaps you're going to use macrolides without confirming the pathogen. So what I intended to explain to you is that we have to be motivated and we have to change our conduct, our medical conduct into diagnostic. If we have the patient inside our hospital on admission and is going to be hospitalized, we must do the important effort to make a diagnostic. We cannot only rely on saying common cold or rhinopharyngitis. We have to say rhinopharyngitis due to some of these virus or an atypical pneumonia due to Bordetella pertussis, pertussis, Chlamydophila pneumonia, or Mycoplasma pneumonia. This is really interesting. In pediatrics, we are seeing right now that even with our vaccination coverage, Bordetella pertussis is increasing worldwide. And this is due to the pressure that vaccination has made for Bordetella pertussis. Right now, we are having pertussis without pertactin. And without this antigen, the vaccine is not going to be so effective. So we are expecting to have more cases, but the cases must be confirmed so we can have an update vaccination schedule for our population. So I wanted you to know that it has this explanation of every viruses. So coronavirus, human coronavirus, different to SARS-CoV-2, are differentiated in this panel. Also influenza, and this is important because if we have right now this alert from the WHO of influenza aviar, if we are expecting perhaps some kind of peak, and why do not say so pandemic for aviar influenza, we are not expecting to be detected by this panel, for example. And also COVID-19 is detected in this, but is not detected in pneumonia panel. So if I want or I'm suspecting COVID right now, I must do this panel, not the pneumonia panel. And as you can see, we can have also differentiated parainfluenza viruses, also RSV, and the atypical that is very important. And I want to show you what's the application. This is a 15 years old female and was captured by the antimicrobial stewardship round. She was sent to us for his pediatrician in the outside consultation. And as you can see, it has a CT scan with infiltrates, interstitial infiltrates on the lung bases. The clinical scenario was typical for an asthma crisis. As you can see, 3 days of productive cough, unquantified fever, and she was started in the outpatient clinic with antibiotic without diagnostic. But because she went on dyspnea and she was on wheezing, she was referred to inpatient um, admission. When she was admitted, the CT scan was performed, and she was, like an adult, performed a gram sputum and a culture of the sputum. At 24 hours in the antimicrobial stewardship round, what we saw was a patient with wheezing and a past history from inhaler use. So we thought it was an asthmatic crisis. And what we know is that 90% of the asthmatic crises are um, caused by viruses. So what we ordered was a FilmArray from respiratory tract and nasopharyngeal swab, and this was detected, the RSV virus. What we said was this is a asthmatic crisis with an RSV pneumonia. You can stop antibiotics. And with the improvement with the crisis, she was discharged for follow up. So the patient was diagnosed. We had the etiology confirmed. She was stopped on antibiotics and she had a correct follow up on the outpatient clinic. So this is how important it is to make diagnosis in our patients. So what's the algorithm proposed for you and what's what we do in our institution? For respiratory panel, we have like a manual for the sample, just you to know what's the correct sample you have to send to microbiology. And we have correct indications. And we almost do not cross these indications. We are very adhere to these indications. So when we have an acute respiratory infection who gets hospitalized, we order the FilmArray because we are not only looking for diagnostic, we are looking for cohortization or isolation. You have to remember that RSV has this cross transmission with contact precautions. So if we don't have diagnostic, we are going to have this patient in a common room, and we are perhaps um, giving the facility to have in our patients the probably risk to contract the RSV. So that's another important benefit from this panel. You can have diagnostic and you can have also orientation of what are you going to do, where are you going to direct your patient, and what is your precaution that you're going to install in your patient. So one of our indication is acute respiratory infection who gets hospitalized, acute respiratory infection that it's acquired after 7 days on being admitted. So if you are into the hospital because you have an UTI, a urinary tract infection, but on day 7 of hospitalization, you have symptomatic respiratory symptoms, you are going to have also the panel because you have the risk of having this infection contracted in the hospital. Also, every acute respiratory infection that immediately at admission has these risk factors is a patient with cystic fibrosis, with a chronic obstructive pulmonary disease, with asthma, is a health worker, or has the chronic pulmonary disease of the neonate, that is bronchopulmonary dysplasia, and also every immunocompromised host in the admission as soon as he gets admitted has, if he has these risk factors, will have the test. Also, if we are suspecting a typical respiratory infection for a typical bacteria, of if the pediatrician of the adult physician is going to start macrolides. We we are allowing our clinics to have the prescription of the macrolides in hospitalization, but we are always asking for them to order the panel so we can know if we must continue the macrolide or we can stop the macrolide. and also in every patient with febrile neutropenia with clinical respiratory syndromes. It's a must. We can not doubt in this population. We have to do the panel so we can have diagnostic and perhaps a surveillance in hospital surveillance without antibiotics. Where do we not process film array, respiratory film array? If the clinical picture is not severe acute respiratory infection, meaning outside patient and is going home, discharged home without antibiotics. If it's already detected by a rapid test, like an immunochromatographic test, some institutions have this like a scale order. Order first the immunochromatographic, and it is not detected, they order the molecular testing. If is an institution with this kind of sequential testing and it's already detected, we are not ordering the panel at uh, except we are suspecting atypical bacteria or co-infections. If we have ventilator-associated pneumonia, we have a lower respiratory tract infection, so this panel is not going to work. And also in not approved samples, we are not testing the film array from respiratory samples of nasopharyngeal swabs. Remember, from this panel, the respiratory panel, the correct sample is nasopharyngeal swab, not any other sample. For pneumonia panel, that as you can see has an amplification of bacteria. It includes typical bacteria that we have in community and also that we can have in ventilator associated pneumonia. So as you can see, we have Acinetobacter calcoaceticus baumannii complex, a lot of gram negatives, including pseudomonas, also staph for complicated pneumonia or sepsis from pulmonary focus. And we have the same atypical bacteria. And as you can see, pertussis is outside here because we're expecting to catch the pertussis only in nasopharyngeal swabs. And as you can see in viruses, you have the same viruses like the respiratory panel, except that you cannot differentiate it from the pandemic H1 2009 influenza or the different lineages for influenza B, and you can have the differentiated parainfluenza virus. And also, it does not include SARS-CoV-2. So if you are suspecting a pneumonia for COVID-19 and the respiratory panel is negative, and now you are suspecting is in the lower respiratory tract, you have to make a monotarget PCR just searching for COVID-19 because this panel does not include SARS-CoV-2 in lower respiratory infection. And one really thing that is very useful is that you also get the genes for antimicrobial resistance. As you can see, make A, make C. This is the cassette for methicillin resistant Staphylococcus aureus. The carbapenemase more common in our hemisphere that are serine and metal enzymes, KPC, NDM, oxalate, BIM, and IMP, and also the most common enzyme for beta extended spectrum beta lactamase, that is CTXM. What is important for you to know is that this panel requires an additional education for the clinician because if it's not well taken, you're going to have endotracheal contamination because as you can see, there is a lot of approval samples that you can take, but in order, the best sample will be the bronchoalveolar lavage or the valve or the mini valve. This is a blinded uh, sample taken from the lower respiratory infection uh, and the endotracheal aspirate. These are my preferred ones, and these are the ones that I have validated from my institution. Sputum is also validated, but you must have a good practice for this sample taking in your respiratory personnel. So in my institution, I have a lot of change in the healthcare workers that are taking the samples. So as I can assure that this is going to be the best sample possible, I only approve pneumonia panel when I can have these three kind of samples. But if your institutions can ensure and assure that your sample is a really good taken one, you can have also the pneumonia panel in sputum in your in hospital patients. So this is a 4-month-old patient. It's a really recent case. As you can see, it has a past history of being a preterm baby, a corrected age of 2 months. He was previously with prolonged intubation. It also has a failed extubation, a cardiac arrest, and he was admitted just only 3 days after he was discharged from the NICU. And then he goes to the PICU because of his age, and he was admitted with respiratory failure since he goes into the ER. He was intubated and he was referred to the PICU. And as you can see, we could perform this molecular testing from the lower respiratory tract. This is a really extensive pneumonia, a bilateral pneumonia, as you can see with the background of a pulmonary bronchodysplasia in the patient. I will retry this one so you can see again our CT scan. So you can see the extent of the compromise. But what you don't think is that it has polymicrobial infection. So it was initially started on meropenem vancomycin, but as you can see with the pneumonia panel, you have to make this correct interpretation and you have to look how many um, like indirect markers of this viral load or bacterial load is present in the sample. So you have to assume true infection when you have more than uh, 10 to 5 folds into the detection of the pathogens. And as you can see, we have a polymicrobial pneumonia with all the known risk factors. And we have Acinetobacter, we have Klebsiella, and we have Pseudomonas. And more interesting than that is that we have detection of the genes. So we know we have extended spectrum beta-lactamase, and we also know we have the New Delhi metallo-beta-lactamase. So the meropenem vancomycin that we started on that mission was not going to have an impact in this patient. And it was only because we have this molecular testing that we can start in this patient ceftazidimia bivactam plus strontium plus ampicillin sulbactam for Acinetobacter and Tigacil to have a correct coverage for this polymicrobial infection. And as you can see, the clinical picture started with a human coronavirus. This is not SARS-CoV-2, as I told you, but this was the first episode, and it was a super infection in a previous colonized patient with a previous history of long stance in our hospital. So we can have this double flow. We stop vancomycin because it was not giving us anything, and we optimize the gram-negative coverage according to the resistant profile that was detected in the genes. Which are our indications for pneumonia panel in our institution? We have also the manual, and we always order gram stain before processing the molecular testing. The gram stain is processed by the microbiology lab, and they have to make this checkpoint. And if the criteria for Murray Washington show them that it's an inflammatory sample, they can do the molecular testing. If the sample is not an inflammatory sample, they have to call us and they have to say, do you still want the panel? Are you looking for viruses? Because we're not expecting bacteria because Murray Washington criteria is not fulfilled and is not an inflammatory panel. But they have to call us so we can approve it. Otherwise, it's not going to be approved if the gram stain is not showing bacteria and if the Murray-Washington criteria is not fulfilled. If the criteria is fulfilled, these are the indication. Every community acquired pneumonia with severity scores for adult population, every curve um, 65 puntation above 3 in adults, and every pneumonia acquired in the community that is admitted to ICU in pediatric population, every community acquired pneumonia that has clinical and paraclinical deterioration and that goes intubated or that goes for bronchoalveolar lavage is every patient that goes for BAL or for bronchoalveolar lavage has this molecular testing order in the sample. Every suspicion of atypical bacteria, very important Legionella, and when we have the healthcare pneumonia in our patients, so we can have the correct identification for Acinetobacter, for Pseudomonas, and these gram negatives. And really important in ventilator-associated pneumonia. Every time we're suspecting ventilator-associated pneumonia, not tracheitis, only when it's pneumonia, we are ordering this molecular testing. And what I want to show you is what do we exclude? We exclude only a patient with acute respiratory infection that, this test cannot be applied in nasopharyngeal swabs. When you have only suspicion for tuberculosis, we do not use this molecular testing. And when we are suspecting Bordetella pertussis or parapertussis, because as I show you, the test has not included this target, is only included in the respiratory panel in nasopharyngeal swabs. And also what I want to show you in the limitations, I think I have it here, is that some pathogens like Stenotrophomonas maltophilia are not included. So if you are suspecting pathogens like this, you cannot be relied on this panel. What do we have in gastrointestinal panel? As you can see, bacteria, a lot of them, viruses, and some kind of parasites. My key message for you, as you can see, there are bacteria that are colonizing our uh, tract, our enteric tract. So not every detection means that you have an infection. It is a key message. When I see bacteria like Clostridioides, when I see bacteria like Shigella, when I see bacteria like Salmonella or Plesiomonas shigelloides or Aeromonas or Vibrio cholera or Vibrio species or Campylobacter or Yersinia enterocolitica, I have no doubt that I must treat them. But when I see any of these E. coli, I must apply the clinical criteria for the patient. Many of these E. coli are in our enteric tract and they are not causing an infection. And this is very common in pediatric population. About viruses, these are the most common. The rotavirus, even in the presence of vaccine, is the first one. And after that, norovirus and astrovirus, and then adenovirus. And these parasites are really important, but really important in immunocompromised host because the modified single cell stain is not reliable because cyclospora and cryptosporidium is really common in malnourished kids or immunocompromised hosts, and because Giardia lamblia has this limitation in the um, normal coproscopic. So you have to do the enteric camera or an endoscope or a low endoscopy, or you can apply the molecular testing. So what do we have? The last time I show you, uh, I show you clinical cases um, in two infants, one breastfeeding and the other one with common meals in the house. One had salmonella, the other did not have salmonella, only rotavirus. And the difference was not the age, the difference was the risk factors of the presentation. And both of them has the same coproscopic inflammatory one. So my key message is that in diarrhea, The coproscopic mm, cannot give you really good choices only if you are seeing the parasites. Otherwise, the inflammatory coproscopy could be viruses or could be bacteria. So as you can see, this is the most complex uh, algorithm we develop for the testing because it can confuse and give us overuse of antibiotics in our clinical stuff. So what is our flowchart? We have to ensure that the sample is an unformed stool, that is diarrhea. We cannot perform this molecular testing in normal stools, except an ID order it. Otherwise, only in diarrhea samples, liquid samples. And this is very important because there is a lot of patients that goes admitted because they have abdominal pain, and the physician wants to make the molecular testing in the stool, and they order it, and the patient goes a normal stool, and you take the sample, you take it into a liquid transport media, and it goes to the lab liquid. So the microbiology is not going to know if it's a good sample or no, because it's already liquid in the transport media. What is important is that the physician knows that he cannot order or she cannot order it if it's not a liquid stool, because we're going to have false positive colonizers of our enteric tract. So what's the flow? If we are admitting on the ER a patient and he has sepsis or shock, or we are suspecting a salmonella or typhoid fever, or if the patient has have bloody stools or clinical deterioration, we are prescribing the panel. If the patient does not fulfill this criteria, we search for another high risk criteria. If it's risk for polymicrobial infection, so does the patient comes for a limited resource setting? Has the patient take any unpasteurized food or any raw milk? Does the patient have any kind of immunocompromise? This is very important. Every HIV patient or every moderate to severe immunocompromise has to have the panel, or if there is a fecal oral rule, prove it, or if there is existence of pets with diarrhea or in close contacts with birds or reptiles like squirrels, like snakes, because they are chronic receptors from salmonella. If it is a no, we only wash the patient. If it is a yes, we also order gastrointestinal film. If the patient is already hospitalized and have more than 3 days of diarrhea and is below 5 years, we know that here the viruses are key agents. So we first perform the rotavirus and adenovirus antigen. This has a good sensibility of almost 99%. So if it is positive, we don't do the panel. And if it's negative, we also ask for the risk factors, and then we order the panel if there is any of these present: healthcare worker, a food processing worker, immunocompromised host, or is over 65 years of age. If there is no comorbidities and it is being over 3 days of hospitalizations, we ask for improvement. If it's not improving, if the patient have still more than 3 stools per day, intense abdominal pain with diarrhea, vomiting, fever, dehydration, or if it gets admitted to the ICU, we order the panel. Also, in our algorithm for Clostridioides difficile, it is uh, always prescribe the panel for Clostridioides, and the criteria is, of course, that has broad spectrum antibiotics, long admission, or that we are facing hospital outbreaks. Where do we not order the panel? When we don't have diarrhea or liquid stools, when are not approved samples, or where there are only digestive symptoms without diarrhea, or if the patient has non-infectious causes of diarrhea like Crohn inflammatory disease. So this is one of our examples, a 4-year male. It was on the ID consult, no past history of relevance. And as you can see, only 2 days of diarrhea, fever and chills, but he was admitted with bloody stool and one episode of abnormal movements. And it was suspected to have a bacterial diarrhea because of the coproscopic was inflammatory. As you can see, no parasites. The stool culture was negative at 48 hours, and blood cultures at admission were also negative. But with this clinical picture, you have to be aware of Salmonella and Shigella, and that was what we ordered. And as you can see, we detected Salmonella, and this is expected to cause even the seizure. But what about the E. coli? Are you expecting to have this like a polymicrobial infection? What we concluded was a salmonellosis, and these were colonizers from the enteric tract. So you must be aware because sometimes you have this E. coli and an adenovirus or a rotavirus in a 1-year-old child that is well appearance. What are you going to do? Are you going to prescribe antibiotics, or are you going to rely and to give credit to the rotavirus in a supervised children in a hospitalized setting? So please, this is a very sensitive test. So it can detect the colonizers. You have to make a correct interpretation with your antimicrobial stewardship program, and remembering that viral pathogens are really common under 5 years of age. But these are the outsiders, these are the off-label usage that can only be approved if the ID order. What I wanted to show you was this patient that 12 days previous to the admission has this clinical presentation. As you can see, antalgin gait, this is after the improving. And we were suspecting Guillain-Barré syndrome. And when we are suspecting these polyradicular neuropathies, we also make this completely infectious diseases kit, and we study for cytomegalovirus, for Epstein-Barr virus, and what we ordered with this past history was the panel in the fecal, in the stools, and what we detected was Campylobacter. And as you know, this is the electromyography, and it confirmed the severe axonal acute motor variant, the AMAN of Guillain-Barré syndrome. And as you know, Campylobacter is the most common related cause of infectious related Guillain-Barré syndromes. So this is really meaningful to us because we had the etiology that is not always possible in Guillain-Barré syndrome. What about meningitis and encephalitis panel? As you can see, bacteria, viruses, and fungi. My key message for you is when to request them. These are our indications. Every suspected meningitis or encephalitis, even with normal CSF. And you know, there is a publication in Clinical Infectious Diseases, the June of 2024, that proved that even in adult population, almost 30% of the normal CSF fluids in the cytochemical analysis had proven molecular testing for viral encephalitis. So it is very important for you to know that when you're suspecting meningitis or encephalitis, even with a normal CSF, you must perform a molecular test. Also, when you have a CSF, of course, with an abnormal gram stain, and also when you have an immunocompromised patient with suspected CNS infection. In immunocompromised patients, you cannot doubt about what you're going to test. You must do this evaluation. Also, you're going to have patients that in the admission does not show you that they have classic clinical meningitis or encephalitis symptoms. But what about rhomboencephalitis? It's one of the clinical pictures when you wanted to have diagnostic and molecular diagnostic. Also, the key message, don't expect abnormal cytochemical analysis. And what are our exclusions? We do not perform device associated, the paneling device associated meningitis because the microorganisms we're expecting are not included here. I mean, as you can see, there is no Pseudomonas and there is no Staphylococcus aureus. So those are the two pathogens that we're expecting. If you are not seeing, if you don't have the target, why are you going to prescribe the panel? If there is another differential organic cause, meaning, for example, uremic encephalitis or diabetes mellitus crisis that you have your neurological impairment, or when you're suspecting only CNS TB infection. We do not order here the panel. But I wanted you to know that every result in CNS panel is a critical value, even a negative one, because it shows you what are you going to do. Because remember, the correct sample is CSF, at least 3 tubes, at least 1 milliliter for each tube. And you have to know that for herpes virus simple 1 and 2 and for cryptococcus, there is less sensitivity, almost 80%, 88%. So if you are still suspecting HSV1, HSV2, you have to order a specific PCR. And if you're still suspecting cryptococcus because it's an HIV patient, you have to do the panel and you have to do also accompanying this test, the lateral flow assay for cryptococcus. This is the patient I already showed you with herpes simple that was not detected in other samples, but these are my two most recently patients. This is a 10-month-old patient admitted really early in January with a 6 hours since fever and this lesion started to appear. 12 hours after was referred like this to our reference hospital and he died within 23 hours of clinical symptoms. And I want to show you that his CSF was totally normal in the lumbar puncture, totally normal. And why was that? Why we have the detection of meningococcal pathogen and we are CSF normal? Because as you saw, it was a really rapid onset infection that conduct our patient um, to this disease. But when the pathology is so rapid um, evolving, the CSF has no time to be implemented. So it's a key message for you, not only in viral encephalitis, also in bacterial infections, you can have normal CSF. And this is really something that we are not always expecting. You at least are going to expect some kind of pleocytosis. But as I show you, that this was totally normal in glucose, in proteins, and in white blood cell counts. And the blood cultures were negative. We only, in this patient was positive, sorry, but we can have also meningitis really quickly and also in sepsis panel detection. And this is the culture. And as you know, this culture was obtained 5 days after, but we did adjust our therapy but we do not have the successful result in our patient. But as you know, meningococcal outbreaks do not present with only one case. 5 days after, we have these 11 years old patients with these lesions. It was first considered for Henoch purpura and not infectious cause, but with this rapid onset of expansion. We also did our lumbar puncture, and he did not have any symptomatic of meningitis or encephalitis. His clinical picture was a rapid onset of this fulminans, purpura fulminans, and septic shock, but without a neurological alteration. It was only altered really when he was on septic shock. So he did live, he's living with the sequels according to meningococcal disease. But what I want to show you is that the diagnosis was only made thanks to the molecular testing. The CSF in this patient, it was it was altered. As you can see, pleocytosis, hyperproteinuria, uh, hypoglycemia, and the LDH elevated, but the gram stain was negative. The CSF culture was negative, even with this purpuric, the purpuric fulminance. I mean, I see a patient like this, and I'm expecting to have a circulating bacteria in the blood, but the blood cultures in that patient was negative, even with extended incubation period. So inflammation was present, but identification was only possible with molecular diagnostic. And we are almost finishing. This is sepsis BCID panel. And as you can see, we order the BCID panel in every gram-negative cocci or bacilli, in every polymicrobial gram stain, in every bacilli, a gram-positive bacilli with risk factors for listeriosis that are these that I give to you here, and in any GIST reported. And we only perform the BCID panel in gram-positive cocci or cocci if we have septic shock of there are at least two bottles positive. Otherwise, we expect the result because we can have contamination. Where do we not order the panel? We do not order the panel if we don't have a confirmed uh, growth in the bottles. If we have a gram that is advised, but you don't order in the first 24 hours, or if it's an inoculated sample from another sterile site different to blood. Why do we have asterisk here? Because if the ID consider in some exceptions, we probably could apply it if the microbiologists agree, but these are not the indications approved from the FDA. Every result, even negative, is a critical value. And I give to you here what we have to do in our institution so we can have a really a good application, and it's having really good practice in blood cultures in adults and pediatric population. This was a patient, an oncological patient with an implantable device that consulted with after chemo neutropenia. So it was a febrile neutropenia and with kind of erythematous um, inside device localized erythema, and it was suspected to have a secretion also from this side. So has markers for sepsis. He was admitted on cefepime vancomycin. We were suspecting and expecting having Staphylococcus aureus, including this device. But as you can see, he has no previous past history of infectious episodes. But at 6 hours, we have the growth of a gram-negative bacilli, and we ordered the BCID panel. This is a recent case also. And as you can see, we had pseudomonas detected. But it's really important you to know is that we have the genes of carbapenemase detected. And with cefepime vancomycin, we were not covering this patient. And if we did not have this algorithm in our institution that with an advice gram order the panel, we probably couldn't have this result, and we probably couldn't adjust the treatment with ceftazidime and bivactam plus aztreonam and suspecting the vancomycin and stopping the vancomycin. So it's really meaningful for me to show you these successful cases. Bone and joint panel is one of the recent um, launches from bioMérieux, and these are the targets. And this, this is our algorithm is still under construction. We only have two panel done already. In the two of them, we have detected Neisseria gonorrhea in polymigratory arthritis in two patients, one 24 years old and one 16 years old. So our indication are suspected septic arthritis or recurrent joint pathologies, even with normal cytological synovial fluid exams or unexplained arthritis in immunocompromised patients. These are the indications approved right now in my institutions, but we are trying to amplify and clarify other indications because the only sample that is allowed is synovial fluid. Of course, the exclusions are uh, other causes of chronic arthritis or samples different from synovial fluid. And tropical fever, we have not constructed it yet because we don't have it, but we are perhaps this month going to have some kind of indications for when it arrives in our institution. As I told you, patients get sick from what the doctors knows, so we have to try to make diagnostic. And in my personal concept, everything we saw in the algorithms is here in a key points where to use it and in the algorithms how to use it. So I'm going forward. And what we're having with molecular testing is that we are getting stronger in the antimicrobial stewardship program so we can have POCT tests for real-time decisions in our patients to have diagnostic and correct treatment. So finalizing, these are my take-home messages. We have to integrate molecular testing into algorithms as a critical value alert, measure your institutional adherence to clinical algorithms, and having antimicrobial stewardship programs. And finally, molecular syndromic diagnosis provides you diagnostic opportunity, guides therapy, allows cohort deciding patients, isolation measures, identification, and containment of outbreaks. Thank you for your time.
Thank you, Dr. Arias. Thank you for this detailed explanation of algorithm combined with practical examples. I listened attentively and was very impressed by this new information. Uh, I want to see in our chat box if we have questions. Feel free to send us your question. I don't see yet. You can send it or in the chat box or in the Q&A box. But meanwhile, waiting for questions to come, I have one question of a couple of questions for Dr. Arias. I want to start like this. Many institutions use a stepwise escalation approach, starting with limited panel, like 4 pathogens, uh, before moving to a biofire panel. And this is in respiratory panel and in GI panel. I want your insight in what are the advantages or challenges in using this strategy.
Okay, I think it's an economical approach, and it depends of the capacity of the institution to allow and to have the capacity of uh, having this recovery of the economical impact of the test. But being really scientific, I show you how for an ID, the more targets we can detect, the more important is the analysis for our patients. And in respiratory panels, we have a really difficult situation. We recognize that at least for influenza and for RSV, there are seasonal peaks. When RSV is not seasonal, the detection rates go below 10%. And you're going to have parainfluenza, and you're going to have um, perhaps metapneumovirus, and you're going to have human coronavirus over 10% of detection. And these limited for targeting samples are not giving you that information. And if you don't know, if you're a physician that don't know what's the circulation right now in your country, and if you have the patient in front of you and you make this only for detection panel, you can have mistakes in the interpretation because you're going to make the analysis saying uh, PCR for respiratory virus negative, but how many did you test? And are you going to prescribe the macrolide because it's one of the most overused antibiotics? So did you apply the correct exercise trying to confirm it? Because the only way so I can use a macrolide is confirming, and the only way I can confirm an atypical bacteria is with PCR. And these four targeted PCRs do not screen for atypical bacteria. So those are the cons that I will find, that you have a limited detection targets in a seasonal changing episodes. As you know, RSV do not behave the same like the year before, now with the climate change that we are experiencing. So you don't know if you're having a pretest probability of a 60% or a pretest probability of a 2% of detection. So you must apply the most possible syndromic, at least in the in-hospital setting. And with GI, I really have a discussion. There is a really, I think, a campaign from other lower, I say lower with really this symbol, lower test for Clostridium difficile, right? They want to make just the PCR for C. diff or for the toxin or just the metabolite that the Clostridoides, when it is metabolic active, is producing, but it has low sensitivity, at least for the GVHD test. So the first difficult, you're only testing for Clostridoides. But as you can see, we can have diarrhea for other enteric causes. So you will finally going to apply if you have a negative C. diff exam and extended PCR. So there are two causes that you are not seeing. And with a direct GI exam, you are not only ruling or confirming the C. diff, you are also getting the insight in the other enteric etiologies. So in with my gastroenterologist, I had the discussion 1 year ago, and I was told them, what if negative? Are you going to do the extended? Yes. Why not the same? I mean, by cost, you are saving. And I showed them that in every 7 of each 10 patients they ordered and escalated, in every, I mean, 70%, they finally ordered the extended GI panel. So we were losing money in our institution. And with virus, I do have below 5 years of age, I do have an escalated approach. Why, Emily? Because rotavirus and adenovirus are still one of the most common viruses in childhood, below 5 years of age. And that rapid test do have a good sensitivity, 99%. A difference of respiratory rapid tests that are below 60%. So if I have a positive rapid antigenic test for rotavirus or adenovirus positive, I stop there, but only below 5 years of age. Everything above 5 years of age, I go straight forward if it's in the algorithm for the GI panel. And below 5 years of age, if it's in sepsis, if it's admitted to ICU, of if there is the risk factors that are very common in my country, poverty, uh, malnourishment, etc., etc., I do the extended panel from GI. That's my vision. I think we are not learning correctly about viruses and the interplay virus between virus between bacteria, because we are expecting pandemics so we can learn from the virus. As you know, previously to influenza, not virus was tested. So we had the pandemic, we have to order to influenza, okay? And then previous to after influenza, not other virus was tested. We have COVID, now we have to order COVID and influenza. And after COVID, there is a vaccine for syncytial virus. So we are uh, pushed to order syncytial. But what about the other viruses? You know, there is a phenomenon in microbiology and in virology. If I have tools for preventing diseases, they are going to be replaced from other viruses. And if we are not seeing them, we are not going to be prepared. So we have to do diagnose. And in respiratory thing, Emily, I want to share with you what has been the impact for my pediatrician. They, since they are using it in the admission for hospitalized patients, the respiratory panel, we have dropped the prescription of antibiotics 76%. So it's a really huge impact. So my antimicrobial stewardship rounds are really easy right now. I go like, I already did it, I already did it, I already did it, because they are seeing the virus and they are familiarized with the consolidative pneumonia caused by virus. If you don't have the detection, you are not going to believe that the virus can have a focalized pneumonia in the chest X-ray, for example. That it's one of the difficulties with the adult population. Everything that have an normal chest X-ray is bacterial and it's antibiotic.
Okay, thank. Um, you have explained about for this stepwise de-escalation or escalation for children. Do you think for immunocompromised uh, adults, this will be a suitable system strategy?
No, in immunocompromised, we don't, we can't be short. We
Mm,
must go to um, rule out every etiology. And it's not Dr. Andres Arias' thought, it's the guidelines prescription. If you're going to see HIV, you have to do everything because it could be pneumocystis, it could be TB, it could be any fungal histoplasma, it could be a virus. If you have oncologic patients, every guideline since 2022 order that if it's respiratory symptoms in a neutropenic patient, you have to make molecular testing and amplified molecular testing. And it's interesting your question, but because the um, last year guideline in adults is really recent,
mhm.
goes like here. Even normal patients, adult population, you suspect pneumonia, you can start on empiric antibiotics. You can start, but you have to search for viral detection. And it goes, I think I did not show you the last webinar because I was centered only in pediatrician, but I have this comparison and the guideline says, please rule out viral detection by syndromic molecular testing panel. And when
Oh,
you say
that's nice.
syndromic, it's
Mm,
amplified, right?
mm.
And then it says, if you detect the virus, you can still look for viral bacterial co-infection, use biomarkers, or clinical evolution. But if you are willing to stay safe, stop antibiotics. If you're still suspecting bacterial, even with a viral detection, go further in other studies of our usual microbiology test. But it's really interesting, and it's a key message that we are not giving to our adult population. They have to. As soon as you say CAP, community acquired pneumonia, you can start on antibiotics. But on the other side, you have to rule out viral infection because 70% of pneumonias in adult population are virus, are not bacterial.
Thank you. We have a question or it's more a remark. It was a great presentation, and although I joined late, I enjoyed the presentation. Uh, question is if they can have the presentation
Of
and
course, you can have it. I think Farmingpex is going to check with compliance that everything is
exactly.
according to internal compliance, and after that, you can have it. My email I will be posting right now on the chat. Uh, feel free to contact us or with Farmingpex. I think we can share our experiences, what I been what I have thought, what I have learned, Emily, in my trips to other countries with molecular testing, is that when it's a new technology, we tend to not believe in the technology as soon as it gets right. So if we have polymicrobial infection, we start doubting about the detection. If we have the BCID panel detecting 3 pathogens in the blood, but with the normal culture only one, the microbiologists are like, okay, I will wait
Exactly.
and I'm going to report only the culture. So the patients miss the opportunity to have the correct coverage. We are missing the opportunity to know that are polymicrobial infection. And we are doing the same with higher cost. We have to believe in the test. And if we apply it in the correct patient, right time, right sample, the detection that you get is the detection that you must believe in, and you have to take a rapid response on the patient.
Yes. Thank you. I have this my curiosity. My last question. All the algorithm implemented in your institute is joined naturally with good software from IT and stuff. Otherwise, you can go choose all the algorithm you have. But for me, do you think that in the future, a AI-driven algorithm will be in place? And what do you think about this and for decision making?
I think AI with this kind of new modern language approach, the it's called I'm missing the word, uh, agents. It's the last thing that we have been talking about, artificial intelligence. I think agents will change the world of algorithms as we see it, and perhaps they will scan the history in real time. And if the doctor is missing the test because he did not think it was necessary, the algorithm will uh, talk you back and say, please order the test because it fulfilled the criteria and it will be benefit. And I think it will be really impressive because it will give us the data that is missing, that is the impact in cost for institutions. I always have these fights with the directors, and I think it's a good fight to have. I always say to them, what about images? If you are having the patient on the morning and you order an MRI, a simple MRI, it's okay, it's approved because we know MRI since a long time ago. But in the afternoon, the other pediatrician goes and says, oh, we have to apply contrast. So it's not simple. Oh, it was already taken. Okay, but order MRI with contrast. Okay, another MRI with contrast. And it's already done. And it's already in the accountability for the hospital. And it's not being like, it's not being like vigilated, like we don't have the eyes on it because you repeat it. But no, you do a molecular test. Everybody is asking, why a molecular test? Why do you want the result? What are you planning to do? It's difficult because I think molecular testing is driving us to another level of medicine. We are passing out the 70s, 80s, 90s, and 20s of only having the clinical guidelines. We're passing out to making diagnosis. And this is really interesting because what physicians must pursue every day of their lives is diagnostic. You do not apply chemotherapy in a patient without confirmation of the type of cancer. You do not apply it. You say, I have this biopsy, but let's wait for the immunomarkers so I can say which kind of leukemia do you have. So I can say what protocol I'm going to apply. Why now in infectious diseases? Why now I see this is your upper respiratory tract infections. Let me see what's your virus. Let me see what's your typical bacteria. So I can say what's the best approach I can give to you. I think it's the best comparison that we can have. Why in oncology patients do we wait for confirmation? Why in infectious diseases we are just so simple thinking that pneumonia, antibiotic. What about exercise to make diagnostic?
That's a wonderful approach. Thank you, Doctor. We are coming to an end to the webinar. I want to thank you, Doctor, for your passion for advancing diagnostic solution and your dedication to educating others on is truly inspiring. We deeply appreciate the time and the effort you have taken to share your expertise with us. And on behalf of Pax, I want to thank everyone here and for making time to be with us. And and also on behalf of Pax, I want to thank you, Doctor, for addressing these complexities and this important topic with so clarity to our audience. I want to encourage everybody that is in this webinar to fill in the survey and give us also your feedback on future topics you want to see on molecular diagnostic. Filling in the survey, you will get a certificate of participation to our webinars. Once again, thank you, and we're looking forward to future opportunity, a doctor, to learn with you and from you. And to everybody, thank you till next webinar.
Till next opportunity, hopefully will be face to face. Let's wish for it. Emily,
Yes,
thank you. It's really, I'm really grateful. This is a kind of opportunity to trying to make it better for our patients and better for our institutions. Have a good day.
have a good day, doctor. Have a good day, everyone. Thank you again for participating.